Hello everyone, welcome, and today we are going to discuss one very important topic of ENT, that is acute otitis media. So basically when we talk about the acute otitis media, so it's a bacterial or viral infection of the middle ear which usually accompanying an upper respiratory infection, and patient generally present with the symptoms like otalgia, also often with the systemic symptoms like fever, nausea, vomiting and diarrhea. And this occurs especially in the very young children actually. So let's see what is acute otitis media, what are the signs and symptoms, what is the pathology, how to diagnose it, how to manage it, what are the preventive measures that we have to take in consideration while treating the patient with acute otitis media. So actually we already discussed that what are the signs and symptoms patient will present with acute otitis media and what is acute otitis media. But when we talk about one particular definition, then acute otitis media is defined as an acute middle ear inflammation which is characterized by the signs and symptoms of middle ear inflammation with or without the presence of effusion of less than 3 weeks duration. So generally when we do otoscopic examination, we found in these patients that they have the bulging eardrum, that is tympanic membrane with pus. So before we start the acute otitis media, the disease proper, let's discuss a little bit about the anatomy of middle ear. We know that acute otitis media means infection or pus in the middle ear. So middle ear is also known as tympanic cavity, right? It's behind the tympanic membrane. So tympanic cavity which is covered by mucous membrane. So when we talk about the contents of middle ear, so we have ossicles. So these are the three small bones that are connected and transmit the sound waves to the inner ear. And these bones are malleus, incus and stapes. So medial, lateral to medial, it's malleus, incus and stapes. We also have ET tube, that is our eustachian tube. So basically this is one canal that links the middle ear with the back of nose, that is nasopharynx. And what are the functions? When we talk about the functions of ET tube, basically it maintains the pressure of middle ear and also helps in the ventilation. Now after the anatomy of middle ear, now we will talk about the etiology. What can cause acute otitis media? So basically acute otitis media can be due to multiple organisms such as virus, bacteria, right? And the most common cultures which are obtained in acute otitis media are bacterial cultures, especially the Streptococcus pneumoniae. So Streptococcus pneumoniae is the most common bacteria which can cause acute otitis media. After this, patient might have acute otitis media because of the Haemophilus influenza and Moraxella catarrhalis, right? So when we talk about the bacteria, Streptococcus pneumonia, Haemophilus influenza and Moraxella catarrhalis, these are the three bacteria that can cause acute otitis media. And out of these three, Streptococcus pneumoniae, pneumococcus, is the most common bacteria. The common acute otitis media viruses in children are respiratory, syncytial virus RSV, rhinovirus, coronavirus, parainfluenza, adenovirus and enterovirus. So patient might have acute otitis media because of these viruses also. Adenovirus poses the greatest risk of causing acute otitis media after a bout of upper respiratory tract infection. Because when we talk about the upper respiratory tract infection, what are the most common viruses? So generally we see that patient might have flu, like patient might have RSV infection, right? Coronavirus infection, adenovirus infection. So especially when we talk about the risk of acute otitis media, which is higher in patients who have upper respiratory infection of adenovirus. So after etiology, now we will talk about what are the stages of acute otitis media. So patient clinically can be seen in any of the stage that we are going to discuss now. So the first stage of acute otitis media is stage of hyperemia retraction. So this is the basically onset of disease and it is characterized by the generalized hyperemia of the mucoperiosteum. We know that the tympanic cavity, that is the middle ear cavity, is covered by mucous membrane. And patient might have the symptoms like mild earache, ear fullness and fever. Also very characteristically it is observed on the otoscopic examination in acute otitis media patient that they have erythematous and markedly retracted eardrum. So this is known as very famously the cartwheel appearance of tympanic membrane. So the second stage is stage of exudation. So this stage marks the outpouring of fluid from the dilated permeable capillaries, and also the symptoms which patient already have in stage 1, they are aggravated, especially the pain and fever. And also on the otoscopic examination, what we can do, we can appreciate a very red and thickened bulging eardrum with loss of light reflex. The stage 3 is the stage of suppression perforation. So during this stage, actually what happened, the eardrum ruptures, and whatever the fluid is there behind the eardrum, that starts to discharge, and that we can see in the external auditory canal. So when the acute otitis media and followed by perforation of the eardrum, and when the discharge we can appreciate in the external auditory canal, that is outer ear, then we called it suppurative acute otitis media. So actually what happened in this stage, that the pus is drained, right? So because of patient will have relief from the fever and pain, but the hearing loss seems to be worsened. And in stage 3, this discharge of pus followed by the tympanic membrane rupture is known as very famously lighthouse sign or pulsatile otorrhea. Stage 4 is stage of coalescence and surgical mastocytosis. So this stage is marked by a milder recurrence of pain, also mastoid tenderness and fever. Actually, mastoid tenderness and sagging of the posterior superior wall are revealed upon the further evaluation of the patient. Stage 5 is stage of complications. So this stage marks the extension of infection beyond the middle ear. And the stage 6 is stage of resolution. So this stage may occur at any stage of the disease. Now we will talk about the epidemiology. So basically acute otitis media can affect any age group, though it is seen in the studies that it's more common among the children younger than 3 years of age. And 2/3 of the children are expected to have one episode of acute otitis media during the childhood, and 1/3 of them will have more than 3 episodes before they reach to the age of 2 years. Thus, we can say that yes, age is an important factor in the incidence of acute otitis media. Now we will talk about the pathophysiology. So when we talk about the pathophysiology of acute otitis media, since we already discussed this in etiology that both viral and bacterial infections can cause acute otitis media, right? So let's imagine that one patient have upper respiratory tract viral infection, and because of that there is inflammation in the nasopharynx and ischiation tube, right? And also there is increase in the inflammatory mediators, right? In this condition, patient might have increased bacterial colonization and adherence, and that will further lead to decreased mucociliary clearance of the nasopharynx, ischiation tube, and the middle ear mucosal cells, right? And all these conditions, they will ended up with ischiation tube dysfunction or obstruction. So since we know that ischiation tube connects our middle ear with the nasopharynx, and when we talk about the functions of ET tube, ischiation tube, what are the functions? It ventilate our middle ear, it maintain the pressure of middle ear, it clear all the secretions from middle ear, right? So when it's obstructed or dysfunctions, what will happen? There will be development of negative pressure in the middle ear, right? There will be collection of fluids, right? Also because of this obstruction and all, there will be mucus production and development of the middle ear effusions, right? And also there will be reflux of the colonized otopathogens and the upper respiratory tract infections like viruses into the middle ear space, right? Also we know that we have the immune functions, right? So because of the immune and inflammatory responses in the middle ear, there will be development of purulent material. So since we already know that our middle ear, the tympanic cavity is covered by mucous membrane, so the characteristic appearance of the discharge from middle ear which differentiated from the middle ear from the outer ear is there will be one muco component in the discharge, right? So because of all this, the patient will present with the signs and symptoms of acute otitis media. So now we will talk about what are the risk factors. What are the risk factors because of that one patient might develop acute otitis media. So actually the risk factors of acute otitis media are not exactly involved in its pathophysiology. Rather, their presence may indicate a high chance of acute otitis media occurrence. So the non-modifiable host-related risk factors are age, sex, race, genetic predisposition. When we talk about the environment related modifiable risk factors, so exposure to smoke, poor socioeconomic status, congested living conditions, right? Daycare center attendance, previous use of antibiotics and bottle feeding and use of pacifiers. The additional host related risk factors which are identified, they are premature birth, allergies, immunological deficiencies, cleft palate defects, craniofacial abnormalities and the adenoid hypertrophy. So what are the signs and symptoms of acute otitis media? So one infant and children might have one or more of the following symptoms. So basically when the patient, one infant or children present in our OPD, so the attendant like the mother or father of the children or infant, they might complain that the child is having excessive crying, irritability, sleeplessness, pulling of the ears, right, because of the irritation and ear ache, ear pain, also headache, neck pain, feeling of fullness in the ear. Patient also, if there is perforation of the tympanic membrane, so there might be drainage of fluid, fever, diarrhea, vomiting, lack of balance, right, vertigo, and patient might have hearing loss. So after signs and symptoms, let's talk about the diagnosis of acute otitis media. So basically the key for diagnosis of acute otitis media is good clinical history and the otoscopic examination of the tympanic membrane, right? So when we talk about the signs and symptoms or a good clinical history and otoscopic examination of the tympanic membrane and going for the diagnosis of acute otitis media, then we always try to classify the symptoms, right, basic on the severity. So the mild symptoms, when we'll classify, when patient will have mild otalgia with the duration of less than 48 hours and the temperature less than 39 degrees Celsius. Now, if the patient have otalgia with duration of at least 48 hours and temperature more than 39 degrees Celsius, then we will classify it moderate to severe acute otitis media. So apart from this, patient must have the history of acute onset, that is within the 3 weeks, and also the signs and symptoms of middle ear inflammation that we discussed in our last slide, and also there should be presence of middle ear effusion. So now we will talk about the otoscopic findings in acute otitis media. Since otoscopic findings are very important when we diagnose one patient with acute otitis media. So patient might have limited or absent mobility of the tympanic membrane. Why? Because in the early stage there is retracted tympanic membrane, and then in later stages either there will be perforation or the bulged tympanic membrane, right? So because of that there will be limited or absent mobility of the tympanic membrane. And it's important to note that when we do the otoscopic finding or examination of the tympanic membrane, then this is the most important parameter. If patient have limited or absent mobility of the tympanic membrane, so that is one characteristic finding of the tympanic membrane in acute otitis media patients, right? Patient might have cloudiness of the tympanic membrane, bulging of the tympanic membrane, markedly retracted tympanic membrane, and distinct erythema of the tympanic membrane. We know the characteristic appearance of the tympanic membrane in acute otitis media, right? In the hyperemia stage, that is cartwheel appearance of the tympanic membrane. Also patient might have air fluid level or air bubbles behind the tympanic membrane because the eustachian tube is not obstructed throughout the time. Sometimes it's like partially there is the secretions are drainage. So in that condition there will be air bubbles behind the tympanic membrane. And we know that when the acute otitis media, when we have the perforation discharge of the pus, what we call that? Suppurative acute otitis media. So there might be perforation with otorrhea. As we know, the characteristic finding is the White House sign, the pulsatile otorrhea. So these are the otoscopic findings we can appreciate in one patient with acute otitis media. So the next diagnostic modality in acute otitis media is pneumatic otoscope. So we all know that middle ear effusion is an important criteria for the diagnosis of acute otitis media, right? So to diagnose that, we can use pneumatic otoscope, and it is having the sensitivity of 70 to 80%, right? And it's good technique for determination of middle ear effusion. We can also advise the patient for tympanometry. So in this, what we do to assess the middle ear condition, we pass 3 probes through the external auditory canal, and we try to measure the tympanic membrane compliance, that is mobility, and the middle ear pressure, right? So basically, this is not usually recommended for the diagnosis of acute otitis media, because most of the time what you found here, the type A or normal tympanogram, that does not rule out the effusion. So a type A graph that tells us that the compliance and middle ear pressure is normal, which is not there in the acute otitis media, right? And also the disadvantage of using tympanometry is like when we are talking that acute otitis media is very common in infants and children. They are below 3 years of age. So there the most common problem that one clinician faces compliance. Patient is not compliant. So because of that, we generally don't perform tympanometry because it requires a good seal of the ear canal. So the next modality is tympanocentesis. So as the name implies, in tympanocentesis, what we do, we try to remove the fluid that is behind the eardrum, that is our tympanic membrane. So basically this is the gold standard for diagnosis of bacteriological diagnosis, but not usually indicated in diagnosis of acute otitis media, because we are again and again talking that the key of diagnosis of acute otitis media is thorough history taking and otoscopic findings. So after diagnosis, now we will talk about the initial treatment of acute otitis media. So the majority of acute otitis media infections, they resolve without antibiotic treatment. So why we are saying this? Because if patient have the acute otitis media because of the viral etiology, then yes, observation is the only treatment. We don't need to give anything. And also the initial observation, especially in children which are 2 years or older with mild symptoms, and infants 6 to 23 months old with unilateral mild acute otitis media. So in these cases, we generally go for initial observation for 48 to 72 hours. So in this time, we will advise the attendant, like the mother of the child, to apply a warm, moist washcloth over the infected ear, and also we will advise to use the over-the-counter ear drops for the pain relief. So when we talk about the treatment of acute otitis media proper, then we know that the most common the chief complaint in patient with acute otitis media are earache, the severe earache, and the hearing loss, right? So we have to give a good pain relief to the patient. So generally we prescribe paracetamol and ibuprofen. So these are the mainstay treatment for providing a good analgesia, especially in mild to moderate pain, right? Also, we will go for the initial observation for 48 to 72 hours before providing the antibacterial therapy. But now what are the indications for antibacterial treatment versus the observation in children with uncomplicated acute otitis media? So say if the children is less than 6 months of age and having the moderate or severe acute otitis media, then yes, we will go for antibacterial treatment. If the same age patient have the mild acute otitis media, again we will go for antibacterial treatment. If the child is 6 months to 2 years in age and having the moderate or severe acute otitis media, we will give antibacterial treatment. Right? In mild acute otitis media, we can give both. We can give for like antibacterial treatment in bilateral acute otitis media, or in unilateral, we will go for observation. When the child is 2 and more than 2 years of age, so for moderate or severe acute otitis media, yes, we will give antibacterial treatment. But for mild acute otitis media, we will go for observation for 48 to 72 hours before we start the antibacterial treatment. So in acute otitis media, where we will give the antibiotic therapy. So if you talk in short, then in children of 6 months and old having severe signs and symptoms of unilateral or bilateral disease. Also in children who are less than 2 years of age with bilateral disease but without severe signs or symptoms. So these are the two groups where we will give antibiotic therapy. And the antibiotic which is recommended is high dose of amoxicillin. So this is recommended as the first line treatment among the patient with mild acute otitis media. Also, if the patient is allergic to amoxicillin, then we will go for the alternative drugs. And very important to note that the duration of antibiotic treatment always depend on the age or the severity of the disease. So when we talk about the antibiotic therapy, after 48 to 72 hours of failure of the initial antibiotic therapy, so since the first line is amoxicillin, so then the first line will be amoxicillin with clavinic acid, and we can also give ceftriaxone. In patient who are allergic to amoxicillin, then we will go for the alternative treatment, that will be ceftriaxone, clindamycin, right? We can also give the clindamycin alone. Still, if patient the symptoms are not relieved, then definitely we will go for the surgical treatment, that is tympanocentesis and meningotomy. And the antibiotics which we generally use in patients who are allergic to amoxicillin. So patient might have type 1 hypersensitivity. So in that case, we will give azithromycin, clarithromycin, erythromycin, right? And when patient have non-type 1 hypersensitivity, in those cases, we will give cefdinir, right? Cefuroxime and cefixime. So when we will go for the surgery? So we will go for surgery when the medical therapy is failed, or either patient already landed up in the severe conditions like suppurative acute otitis media, where the patient have the perforation of the tympanic membrane or eardrum, right? So we can advise the patient for adenoid removal if patient is having the obstruction and dysfunction of the eustachian tube because of the adenoids, right? We know that in children adenoid enlargement is very common. That's why there will be bilateral obstruction of the tympanic that eustachian tube, right? So in that we will go for adenoid removal, we will do adenoctomy. We can also go for the ear tubes. So to drain the middle ear, we will insert the tiny tubes in the ear, right? And these tubes will also allow the air and the fluid to drain from the middle ear. So they will mimic the functions of eustachian tube. So along with the treatment, what are the measures that we have to take in consideration while treating one patient with acute otitis media to prevent the recurrence and also to fasten the healing? So in this, what we generally do, we recommend pneumococcal conjugate vaccine if the child is not vaccinated, and also sometimes we recommend the annual influenza vaccine to all the children. Also, we will encourage the exclusive breastfeeding for at least 6 months, because we know that the feeding that breast milk that have lactoferrin and the secretory IgA antibody, right, that prevent the child from infections. And also we will encourage the prevention of acute otitis media by the reduction of risk factors and the education of patient and the parent, right? We know that socio-economic status, smoking, these all are the risk factors for acute otitis media, right? So these all are the measures that we will take in consideration while treating one acute otitis media patient. So what are the complications of acute otitis media? Though in severe conditions, we can classify the complications in intracranial or intertemporal. Patient might have labyrinthitis, petrositis, mastoiditis, right? Or also meningitis, facial nerve palsy. But in general, if we talk, then patient will have recurrent ear infections, enlarged adenoids, enlarged tonsils, ruptured eardrum, a cholesteatoma, and also speech delay. So these are the complications of acute otitis media if not treated on time. So this is all about acute otitis media. So thank you so much for listening, and please do subscribe the channel if you like my work. Thank you so much.